mind your manners because you are live. And I also would like to just talk a little bit about the setup here. So we have a question and answer uh, uh, should be down at the bottom of your screen. Please put your questions in there. We'll try to answer them as we go along. I think we're going to have an opportunity for discussion uh, towards the end. And so at that point, if that, I will try to watch and see if people want to raise their hand. If you know how to do that, you go to your little icon in the attendee section, and you can, I think at that point, you can ask to have your hand raised, and then I can see that, and I will call on you and let you speak if that works out. Um, so today, we have Hui Yang from the College of Engineering, and I met Hui by email, and then I had him join Unified Campus Research Team to kind of talk about some of the things he's interested in doing, perhaps in the context of the new Institute for Biomedical Sciences, Biomedical and Health Services Research. And so it just occurred to me that it would be really nice to have him come in and talk in our Discover series here, because he's eager for collaborations. And so we did not set any meetings up with him for today, but if you are interested in that and you'd like to talk more with him, please contact Linnell Heimbach, because she will be happy to make that happen. So Dr. Hui Yang is a professor of industrial and manufacturing engineering at Penn State, so in the College of Engineering. He currently serves as the PI and site director of the NSF-funded Center for Health Organization Transformation, CHOT, which this has been an interesting sort of collaboration between the College of Engineering and Penn State Health, with Penn State Health being an industry partner in that organization. But also there are some College of Medicine faculty that have been involved in the leadership and implementation of that as well. So, and he's going to tell you a little bit about an event they're having, the CHOT is having next week. So Dr. Yang was the president from 2017, 2018 of IISE Data Analytics and Information Systems Society. He's also been the president of Informs Quality Statistics and Reliability Society from 2015 and 16. And he's the program chair of the 2016 IISE Annual Conference. He's also an associate editor for IISE Transactions, IISE Transactions Healthcare Systems Engineering, and IEEE Journal of Biomedical and Health Informatics. So I'm going to stop a little bit, although, you know, more IEEE automation science and engineering, robotics and automation letters. So he's a very prolific scientist and well-connected nationally and internationally. And I think that he would be a great collaborator for people at the College of Medicine. He's particularly interested in electrophysiology, heart disease, and breast cancer, but I expect that he could be teased into a lot of other types of interactions as well. So I'm going to go away, and I would be happy to have you listen to him here now. Thank you.
Thank you very much, Sarah, for your introduction. And it's my great pleasure to have this opportunity to introduce my research. So today I'm going to talk about digital medicine. So we have in vitro, in vivo study in the College of Medicine, but here I'm going to present the medicine from the engineering perspective, that is in-silico study, modeling, experiments, and analytics for healthcare innovations. So before we get started, I would like to make an announcement. CHOT has a Smart Health Research Colloquium, and it's going to happen in March 24th from 4:30 to 6 p.m. Eastern Time. This is co-sponsored by College of Medicine and CTSI. And we have two wonderful speakers, outside speakers on COVID-19 modeling and the virus transmission networks. So now let me get back to this presentation. So before I really get started, I would like to thank Sarah and for the invitation and also this opportunity to present my view of the digital medicine from the engineering perspective, and especially to the College of Medicine audience. And also thank Nestle and Sarah. They are very open-minded to interdisciplinary research and promoting innovations from clinical and also from technology point of view. And also, I want to thank Chris DeFlich, who is my co-director of the CHOT, Center for Health Organization Transformation. I have been thoroughly enjoying working with him in the past few years, and hear great things about Hershey Medical Center and the College of Medicine, always in the forefront of the technology innovations. So telemedicine and effective COVID-19 responses. And yeah, very much appreciate this opportunity. And Hershey, you have a beautiful campus, and I have a picture in the background too. So, and also, before I get started to introduce all the papers, this is not my individual effort. I would like to thank all of my students and also collaborators. So here is some pictures with my students in the conference, and undergrad students here, undergrad students, and also with the Veteran Affairs Hospital. And I actually went to the hospital and give medical students tutorial workshops on how to programming, how to analyze the data they connected with Holter monitors, connected with during the cardiac procedures, how to analyze those ECG signals, physiological signals with frequency analysis or different statistic modeling tools. Yeah, and many students, they have become professors in different places. So far, I joined Penn State for 5 years. I graduated about 6 PhD students. 5 of them joined academia as assistant professor. And also, we have some demonstration of virtual reality in the lab, and undergraduate students, they are working in the virtual reality medical clinic. So put on the goggles, you can get into the medical clinic and interact with the doctors. Previously, we have behavioral health, and they do a lot of survey design and send out the survey. But now you can put it in the 3D immersive environment and let the patients to feel the new technology and the new immersive environment for health interventions and survey, this kind of survey design. So this is one side of the research, and those are the students who are working with this VR technology in the lab. And also, I would like to thank my collaborators. So in the past few years, you see this picture, I actually worked in the, every week I spend a few hours in the cardiology department of Veteran Affairs Hospital many years ago. And when we had an NSF project together, and we collect a lot of data, and the procedure actually start from 7 o'clock, they get started, the nurses and physicians, they get started to prepare get started to prepare for the procedures, and then 8 o'clock they started to do the procedures, and most of the time 11, 12, and they will end the procedures successfully. But I have seen some sad cases that it will continue until 3, 4 o'clock in the afternoon, and they couldn't really tackle this disease. And then they have to implant the pacemaker in the heart. And during those observations, I see they collect a lot of data, but those data are not fully utilized to build the model and analyze the information so that it can help them make better decisions. For example, tackle those very complicated disease that couldn't be done successfully. So I have my cardiologist friend come to my lab, and who actually introduced those physiological and the cardiology knowledge to the students. And I also went to his lab and teach the medical students on how to do programming and pretty effective engineering and medicine interactions. And I also work with Dr. Eric Bennett, and who is a electrophysiologist. And we work on the ion channels and genetic disorders on the cardiac myocyte, and how this genetic disorder alters activities in the ion channels, in the cells, in the tissues, and also in the whole heart level. And also engineering, I have engineering collaborators. I also do some engineering systems, for example, the factory and logistics and those type of research. And the logistics not only just happen in the factory, but also in the healthcare system. You have a lot of logistics, supply chains. And for example, in COVID-19 response, and a lot of supply chain logistic issues need to be addressed. So now let me formally get into the presentation. And here is a question. And Hershey is very much in the forefront of technology innovations. So, but what innovation will have the most disruptive impact on healthcare in the next decade? So this is a question to the audience. And you may think about it. And some of you might think, if you are doing the genomics, you might think the genomics may be the genetic editing. And for engineers, we might think AI, right? AI is a buzzword right now. And but we shouldn't just leave everything to AI to solve it. And especially when it comes to the domain, clinical domain. And next decade is still have 10 years away, and it's very hard to predict what is going to have the most disruptive impact on healthcare. But we can look back to the past, okay? In the past, what are the disruptive innovations? So to the whole society, to the human society, the first one, what is this one? This is a railroad. And 1800, we have the transcontinental railroad network. And it brings the transcontinental commerce. Pretty disruptive innovation or impact to our human society. So this is a disruptive technology. And a power grid, and 2030, we have the power grid. Bring electricity to the hospitals, to all the industry sectors. So we have the booming of the industry revolutions 3.0, and now we have industries 4.0. And this is the radio. This is a radio, and but I believe most of us don't use radio anymore. We have smartphone, but pretty much when it was invented, it was a big deal, very disruptive, because in 1930, it enables the transmission of the video message to the broader audience, right? In those back at that time, so pretty disruptive back then. And this is an antique, but it is something called TV, and it's different from the TV that we have now at home, but it's indeed TV in 1940. Okay. And it was disruptive because it enables the video message in addition to the audio. The video message come to the mass audience. And also interstate highways. So transport a lot of goods, supplies to healthcare systems, to all the grocery stores, make sure everybody have enough supplies even during the pandemic. And 1950, we have the interstate highways. Starting from 1950, we start to build such infrastructure. And brings the economic booms, right? So pretty big deal, pretty disruptive to the human society. If we have this, make our life better. And also this optics, fiber optics, now everybody has high-speed internet, and we are staying at home, and we can also work from home because of the high-speed internet, Verizon Fios, and all these internet providers. But the backbone is actually those optics and pretty disruptive innovations. So my question is, what do they have in common? So those are the disruptive innovations in the past, but if we want to see what do they have in common. So if it is in-person session, I will have interactions, but here, here, let me tell you the answer. Networks actually transform the society. Okay, and we just talk about the network enable the transmission of goods, information, data, and for example, the real world network. We build networks, human build networks, right? And telephone networks, electric grid, and agriculture industry, and different kind of networks. And they are all disrupting innovations. And so let's think about what does it mean for healthcare? And healthcare, definitely healthcare have different kind of innovations. But if we look back and what networks will bring to healthcare. So if we look at the internet, so this is internet users as a percentage of country's population. And as you can see here, United States, and we have about 70 to 79% of internet users. What's the total population? It's about 328 million, to maybe we can increase to 400 million, close to 400 million. But it's about in this amount, 328 million people. And now, if you look at Asia, like in China, there are 1.3 billion people. And also India has more like 1.4 and 1.3 in that magnitude. So, but in these countries, we have, there are 50% to 59%. And India has a 30 to 39%. A large population now have internet access. So internet has changed quite a bit in the past few years, pre-internet phase. So we have Motorola, and you can send SMS text message, right? And Motorola was a giant. And then we have internet of content, then emails, information, entertainment, 3W. So Yahoo, and if you can still recall this website, but now everybody talk about Google, Microsoft, and internet of service. And it comes to the Amazon, eBay, and then internet of people. We have social media. You see everybody now using this is actually network of people. And it brings the social dilemma to our society. So social media, we have Facebook, Skype, and YouTube, and Twitter. And what about Internet of Things? This is the next generation, Internet of Things. How about Internet of Health Things? And you can have Internet of machines, CT machines, on all different kinds of machines. So we are having evolutions, right, from networks, and then we have service on the networks and application on the networks, and then objects, device, and data, and then data and ambient context. So what does this mean for healthcare? And so we are moving from Internet of People to Internet of Things. You see, 2020, we have world population 7.6 billion. But how many connected devices to the internet? And 212 billion. And this is still increasing. Think about the smart home, smart health, smart manufacturing, and a smart industry, right? So this is not just for healthcare, for all the industry sectors. And people connect to the internet. Now things are connected to the internet. And then things connect to things. And if we look at healthcare, we have telehealth, telemedicine, mobile health. People use different terms, and sometimes they're trying to build the network in different ways. And we have sensors and wearable sensors like EKG sensors, smart shoes, and we have smart watch, and smart watch now can measure the heartbeat and all the sleep activity, all the activities. And so this means we are building the network, but are we there yet? So Internet of Health Things has broader impact on the determinants of health. So if you look at it from a person perspective, that's an individual. Now, and then you can individual lifestyle factors, smart and health, right? Smart health and wellness. And then you can go extend it to the social and the community network. Then it will come to the population, social health or population health. And then you will have living, working condition, unemployment, all these kind of things. And it will come to the diversity, inclusion, and all those factors, equity of the healthcare access. And then the general socio-economic, cultural, environmental conditions. So everything is connected through the network. So IoT does have broader economic impact based on those consulting report. The predicted global worth of IoT in healthcare is about 2.5 trillion. IoT device, the total number of IoT devices, about 30% they are in healthcare and 69% elsewhere, for example, in the different industry like manufacturing. And IoT deployment will drive down cost from clinical and operational inefficiency by roughly 25%, or about 100 billion per year. think about this kind of impact to the healthcare systems. And Hershey Medical Center is in the forefront of the telemedicine. And we quickly, from my colleague, Chris DeFlitch, he told me we quickly get into the telemedicine in the very beginning of the pandemic. So now, with the telemedicine and all the infrastructure, and we connect all the data, not only from the individual, but from the network data. So the data are not just the predictor and the response variable and the simple model, right? We have all the connected network data. So now most of the analysis in the first level, and we visualize the data and gain some insights. But we can go beyond that. We can extract useful information and the new knowledge, derive new knowledge, and then gain a better understanding of the disease physics through individual level or population health level study of the people. And then we have wisdoms and intelligence. We call it smart health or digital medicine. So this is a data power. But data itself is raw data. It doesn't mean if you have data, you have power, right? So you have to build models on the top of data and then realize the full potential of those data. And we have several projects before on the digital health network. And one of them is the mobile and e-network smart health. The second one is the sensing, modeling, and optimization of post-operative heart health management. Because when I was in the hospital, and I mean, a lot of cases were done in the hospital. And then when the patient got back home, they were experiencing the same procedure, but they have different outcomes. Some of them have complications, others don't. So we were wondering, how do they manage the post-operative heart health? And can we use wearable sensors to track those activities and gain some new insights on this process? So this is one of the projects. And we also fabricate sensors. You see the small sensors we fabricate, and we put it in the iPhone and Android systems. So that's in one of the project, mobile and e-network health. That project is just for the fabrication of sensors and put it in the IoT device, and then get it into either Apple platform or Android platform. So those are some, I'm not just talking here, but also we have some papers and including the patents about those activities, and including the network modeling and Internet of Things for smart and connected health systems, and a case study for smart heart health monitoring and management. And in different venues, we are talking about this kind of mobile health and digital health network. So now let me talk about, this is about data connections. Think about it, everybody in the bigger network. If you have a smartphone and you can connect the heart signals, and you can see you can match people from Japan or from anywhere in Europe and with somebody in the United States to see whether they have very similar heart patterns or heartbeats, right? So this presents great opportunity. So we call it Internet of Hearts. And if you search the literature, Internet of Hearts, and that's the first time we coined this term for the first time. But this is not just that simple, because network modeling. So first, the activity actually, that's complicated because it's changing over time. For a single person, we have bit-to-bit network model. That means the network is going to change over time for a single person. And also for patient to patient, also the network actually, this means there are two levels of network. You can build the network for a single person. Also, single person can become a node in a larger scale network. That is called patient-to-patient network model. And that's the two level of model, network model. And also, it's not just the EKG, it's like one dimensional, right? And when we do the EKG in cardiology, they actually do it in multi-dimensional. That means it's like a camera. We're taking a camera of the heart of a person from the front, from the back, 360 degrees. But a 12-lead EKG is well designed to get all the information from the heart. So that means if you only take one channel and then compare and do the pattern matching, it won't work. So that's why we propose to compare 12-lead EKG. And that from multiple dimensions, we want to compare how this person's activity is similar to the other person. But this needs to be done in a larger scale. And so this is the trajectory of the heart activity. This is something called vector cardiogram. Vector cardiogram means you look at the EKG in the three-dimensional space. And then you see how the cardiac vector is moving in the space. And then you see whether this person has a similar cardiac vector movement as the other person. So this is, so when we do the comparison, we are doing the spatial-temporal comparison, not just the one-channel EKG and comparing the time domain. So this is an overall framework, and every patient has cardiac signals, and we also have Internet of People, right? And also a database. So you can do the pattern matching, and you can see who is similar to who. And then you can do the network model, and you see all the people will self-organize. And if this person is very similar to the other person, they're actually very close to each other in the network. So that's, they self-organize and form a group. And we have a paper on self-organizing behavior. We didn't tell, oh, this person is hypertension. We just let them compare to each other, and then self-organize and form a network. And then you can see who is close to whom based on his heart signals. Now, people will have a concern. No, now we have HIPAA requirement and all the privacy concerns, right? How come you can just share the data, right? So that's why on another end, we are starting the privacy preserving analytics. So we develop a new method, enable automated protection for sensitive data. So this is a Penn State news about one of our paper. You see, Netflix had a competition. They canceled recommendation competition because of the lawsuit over the privacy, customer privacy. And people say, if you want to protect privacy, just make the data like anonymous, right? De-identify the data. But Netflix has already de-identified the data, but people has ways to recover the information because they can link different database. And in this case, Netflix pay a lot of penalties about leaking the customer's privacy because there's a movie website called the Tomato, and then people actually use the information from that website and then link to the this context, and then they can identify the people in this context. So anonymous is not the only way. There's a new way called a differential privacy. We actually do the differential privacy. So this is a quote from me, and I also do the cyber attacks increasingly see in the manufacturing, but similarly for healthcare. And this brings unexpected disruptions to routine operations and the cost millions of dollars, right? So they can infer the information, and either manufacturing or healthcare, they are backbones of the nation's critical infrastructure for economic growth. So there's urgent need to protect privacy information for either manufacturing or the healthcare enterprise and minimize the risk of model inversion attacks. So this is a privacy. We have two papers. I'm not going to dive into the mathematical modeling details, but I want to present as many papers as we are doing in the past, and from my research team and also from the CHOT, so that I can give an overall picture of what we have done for healthcare. So this is one paper, Mosaic. We develop a new privacy preserving mechanisms for healthcare analytics. So if you invert the model and a hacker can, if it is unprotected model, he can get into the information. But if it is a protected model, you won't be able to access those information. So this is a basic idea. For more technical details, you can refer to the details of these two papers. Now, so far we talked about the network and the data acquisition and also analytics. Network analytics. Now let's get into the modeling. So from the data, how to build the model. In engineering, we have different ways to build the model. There are three different ways, and one is a physics-based model. That means you know you use differential equations to biomechanics and biophysics. You can build the model. For example, the reaction diffusion model. And also ion channel kinetics, they are all differential based, differential equation based, ODE, PDE based. And then the second is called statistical model, or you call it informatics. This is a data driven model, purely from the data. And also in engineering domain, for example, in industrial engineering, we actually do a lot of optimization. And we do the hardcore optimization, like integer programming, nonlinear optimization, linear optimization. Many of the methods that developed in industrial engineering, they were used in computer science to do the AI. But we focus on the core optimization from methodology. So those are the 3 different types of modeling. But they geared up with actually interact with each other. So you have data, right? And then you have also physics and also optimization. And so here are some models we developed. This is a whole heart model. And we did the drug design and pharmaceutical study with one of the colleagues in the College of Medicine. And also we do how the drugs impact the ion channel activities. So this is ion channels. And also we do data-driven modeling. This is a waterfall plot of the EKG for the same person. And over time, how does it change? And also the torso modeling. So here, this is the vector cardiogram, how the cardiac vector is moving in the space and also over time. Now here is a whole heart simulation model. And this is a YouTube, we have a YouTube website and channel to highlight all the research demos that we have. And we stimulate the heart and we pace the heart at different locations. And as you can see, they have different behaviors. So this is not just a visualization. Actually, in the background, there are physics behind it. And we actually developed the 300 million cells. They interact with each other. We have a parallel computing actually package developed on the something called CUDA. CUDA is the NVIDIA graphical processing units. And we actually distributed the computation to about 10,000 CUDA units. Every unit actually compute, and then they interact together to generate this whole heart model. So whole heart model, we have a few publications, and this is a whole heart model. And that's physics-based. And also, we also do the heart and the body surface potential mapping. Because the heart is like an engine, right? Generates the electric activity. Then it will get propagated to the body surface. And if we go from the body surface potential mapping, so this BSPM is body surface potential mapping. If we go back to the heart surface potential, this is called inverse problem. If we go from heart to the body, this is a forward problem. And but for many times you will not be able to measure the heart activity inside the body, right? But you can measure a lot of activities in the body surface. And as you can see, at each location and also at every time point, and this will change. And so, how do you do this kind of heart to body projection or prediction? And you can do it according to the physics. So we actually do it according to the physics, but it does not always measure with, agree with, match the data measurement. So that's why we develop a new model, and we cleverly integrate the data-driven model with the physics-based model together. You see here, this R is the physics-based interrelationship. This is actually derived based on the electrophysics and pretty much the Green theorems. And then we have the physics interrelationship. And also we need the spatial regularity and also temporal regularity. And then we develop an algorithm to optimize this function to do the prediction of X. So from Y, the body surface, to the heart surface. So this is a new model we developed. And here are some, so I skipped the mathematical details, but if you're interested in this problem, definitely there are a lot of collaborative opportunities here. And I will be happy to dive into details, and maybe I can give a specific talk on a specific technology. But here I want to give the overall picture about the modeling. So now let's get into the data-driven model. Previously, we talked about physics, and you use physics to do the model, either the whole heart model or the heart to body surface mapping. Now let's get into the data-driven model. So data-driven here, we have EKG signals. And not just the one channel, we have three channels. The problem we are starting here is, can we use a mathematical model to exactly replicate the waveform? That means if you have 3,000 data points, each channel has 1,000. You see, each channel has 1,000 data points, right? If we use a mathematical model to represent, it can exactly fit the curve, then we will be able to use a mathematical model to represent the heart activity. And the mathematical model only need a few parameters, very sparse set, maybe 20 parameters. That means you can exactly replicate the curve, but you reduce the data amount from 3,000, maybe, and then reduce it to 20 or 30. You see here. And first we fit the bigger peak, and then we fit the second peak, and then we continue to add the Mexican head. Mexican head is a mathematical function. We call it Mexican head. The function actually looks like a Mexican head, but it's a mathematical function. We can fit the curve, and the more Mexican head we use, and the better the fit will be. You see, the 99%, we can fit exactly the curve. So in this way, you see only 11 Mexican head. That means 3,000 data points is reduced to 12 Mexican head. And then you can retain 99.779% of the curve. Of course, you have residues, but if you use more, you can retain more. So this is called data-driven model. Just based on the data, we use a mathematical model to fit the data. And this is a paper on how to do this kind of modeling. In addition to the 3-channel ECG or the one-dimensional time series, and also we do the image. This is a transient calcium image. One of my colleagues in College of Medicine, he's doing the kidney cell. Kidney cells, they have abnormalities on the calcium imaging. So he used a microscope, fluorescence microscope, to see how the calcium channel behave over time. And he wants to know how many, not only how many calcium spikes, but also what is the shape of the calcium sparks and how they are different from each other. So he told me that, oh, he has ImageJ. ImageJ is an NIH image processing tool. And but ImageJ cannot fully accomplish this his objective. So I said, why not we do a data-driven model? Then we use the Gaussian function. You see, this is a Gaussian function. And if you add a few Gaussian functions together, you can replicate almost any geometry, like the mountains, any geometry, complex surface. So we actually develop a basis, this kind of Gaussian function. We add multiple of them together. And then not only we detect, but also we model exactly the calcium spikes over time. So this is another example of data-driven model. So far we talk about physics-based model, data-driven model. Now let's talk about a little bit about optimization. In the medicine, we know that every patient's condition change over time, right? For example, this patient has breast cancer. Cancer may be in different stage, and then she may be in different age, right? So this is her state right now. And if she take a medical treatment, for example, chemotherapy, radiation, then she will get into a new state next year. So our study is trying to model this kind of transition. And if you know that NIH has a database called a SEER database, it has about 1.8 million records of breast cancer patients. And it's a very comprehensive database. So through that base, we can get those information. We can study this kind of transition dynamics. We can model this kind of transition dynamics. And this kind of transition dynamics give us an advantage. That is, you can do the multi-stage decision making. We have something called Markov decision process or dynamic programming in engineering. That means we can optimize the action this patient can take and then sequentially optimize the quality of life over the time epochs. and of 20 or 40 years based on the historical data. This means we can build the Markov model for multi-stage optimization of intervention and treatment strategy in breast cancer. Okay, so this is one example how to use optimization to help medical decision making. So we talk about the sensor networks and analytics and modeling, right? Modeling, we have 3 types of modeling: physics-based modeling, data-driven modeling, and then it comes to the last one, optimization modeling. Now let's get into the experiments. So you build a model, that means the whole heart model, right? So in the clinical, in college medicine, colleagues, they do have a lot of questions, like medical questions. They want to understand the disease physics, gain a better understanding of the disease physics. And all they have pharmaceutical questions, and they are doing the pharmaceutical design and the treatment design. Or they have surgical questions. Surgical questions means how they do the surgical procedures and where do they burn the tissues, or how they do the surgical planning. They also have pathological questions, like pathology questions, and like medical, included in the medical questions. So in order to answer those questions, we have to design an analysis of experiments. So experiments in college medicine, we call it clinical trials. And sometimes we do the design and analysis, statistic design of clinical trials. But in engineering, we do engineering experiments. And we can either do it on physical subjects, for example, on the machines, or on the human subjects. Of course, you need IIB approval, and you need a lot of enrollment, and it's very labor intensive. But at the same time, you can do it in the computer models. I mean, it's very flexible, and you have a lot of freedom to do the experiments on the computer model. If you have the whole heart model, whatever you want to try on the patient, you can try on the model first, because it has already incorporated the physics and also calibrated with the data that we have collected from the patient. And then you do the design and analysis of experiments, then you can do the statistical analysis, computer simulation, numerical methods, and mathematical modeling. And those will help you to identify therapeutic solutions. And here is a paper about the meta modeling and sequential design of computer experiments. I will talk more about the sequential design because sometimes you do experiments on the computer model. The prediction may not agree with the real world observation. Then how do you recalibrate the model and then redo the experiments? So this is called sequential design of experiments. So modeling and experiments are not new. Computer experiments has been done in the logistics, in the automotive industry, and they are trying to use those models to help them improve the production efficiency, optimize their throughput, and improve the quality. So this is a traditional engineer when we do, but at the same time, we do models for example, in this geographic area, for example, the Penn State, and we can develop a network model. This is all the networks branches, and people actually moving human traffic, they are on the network. And then you can have infection models, and then you do the computer experiments here. So this is a COVID-19 model. We have a COVID-19 rapid project from NSF. We do the computer experiments, and I'm also personally serve in the healthcare task force at the university. We run a lot of experiments and modeling to help the decision making. So here, in any experiments, you can do it in a real world process, real world person, right? And then it's very costly, and you need to maintain the animal facility, and you need to enroll a lot of patients and get their consent and get IIB approval. And it's a large scale study, cost millions of dollars. And you have design variables, and then you want to see the response. And this is similar for automotive, healthcare, aerodynamics, and especially in aerodynamics. Boeing right now, they don't do a lot of physical experiments. All the airplane design, they are actually in the simulation models. And then electronics, semiconductor industry, and the machining. And so we can do the experimental design so that you do effective and efficient experiments. And when I talk with my colleague in physiology, most of the time they do the one factor at a time. That means paired comparison design. They fix all other factors. They study one single factor, and then they see how, if change this factor, how does it impact the outcome. But what about if you have 10 factors? What about if you have 20 factors? And if you do it one by one, sometimes you can, it's very labor intensive, not efficient. At the same time, you may miss the optimal setting as well. So, but on the other hand, you see the computing power that parallel computing, distributed computing, enable us to build computer models. And then those computer models, they're cheap. And once you get it built and you have a lot of flexibility to use this model to do the experiments. But those experiments, sometimes they have gaps here, right? And then you can actually run a few data points in the real world experiments. Then you fit it to improve your model. And then your model have prediction. And then you fit prediction to the real world experiments. If they agree, that's great, right? If they don't agree, you can come back to, you got a new data point. And then you fit it to the model, you recalibrate your model, and then do the prediction again. So this is called a sequential design experiments to bridge the gap between physical experiments or clinical experiments and computer experiments. But it's not that straightforward and easy. I was thinking, oh, it's pretty easy, right? And because you have X and Y. But when I talked with my colleague in electrophysiological domain, and he told me, if you adjust X, you're not getting Y. You're actually getting a curve, functional response. And I said, okay, this is a new challenge, and I think we can still do it. And then we design new method to incorporate this kind of functional response into the experiments. Because in clinical domain of physiology, they have experimental protocols. We have to follow those protocols. And then you have ionic currents under different settings, and then you can have characteristic curves. So what we are doing is take the characteristic curves as our response. And then we do the sequential experiments. They do the physical experiment. I do the computer experiments. And then we do it back and forth and iteratively and try to improve the computational and also experimental efficiency and effectiveness. On the other end, we have VR training and VR models and for medical training and education. So here are some VR models, and also we have medical clinics and for static 3D and dynamic environment. So this is a last slide. And before we conclude, I want to share with you a video, how engineers play basketball. Okay, he didn't make it. And so this is frustrated, right? For an engineer who is not really good at basketball. But this guard is pretty good, and he can play. But what engineers can do? Engineers do the data connection, do the measurement. We got to measure every factor. Similarly for clinical scientists. So we got to get every measurement of every component or every part of this game. In addition to the data, so data itself, although only if you realize the full potential, it will have power. So we need a model. You see, we need to do a lot of modeling, either physics-based model, or the kinetic model, or the data-driven models. So if you connect the data and build the model, and this is what's going to happen. Okay, so this is what I'm trying to deliver: digital medicine and the in-silico studies. So my lab, complex systems lab, and we focus on two applications, manufacturing and healthcare, and we do measurements, the sensors. And based on the sensors, we do the models, and we do the optimization and simulation experiments. And we have theoretical foundation here, and we have a different training from clinical scientists. But I do appreciate the opportunity from Sarah today and to let me present my engineering perspective on the digital medicine, also the in-silico analytics and in-silico experiments and in-silico modeling. So as the last, and I want to acknowledge my sponsors, and in the past few years, and without their sponsorship, and this research, all this research will not be possible. Thank you very much.
Thank you, Hui. That's super interesting. So I don't have any questions in the chat yet. I'm going to call on my audience of 30 plus here to try to think of applications that might be interesting for Dr. Yang to think about. I guess, you know, I have a couple people that I've made notes of that are not in the participant list that I'm going to try to connect you with based on what you told me. It seems like the one place that it could be particularly valuable is when you start to think about a native heart and an artificial heart, or a native heart and an assisted heart, because, you know, it's complicated to iteratively test those, you know, and compare the response. And I think that's, once you start to moving into the artificial, you realize that there's a lot more you want that heart to do than just what you thought you wanted it to do. Like initially you just wanted it to pump blood reliably, but, you know, maybe you want it to be able to respond in the context of exercise, or respond in the context of another pathological state, right? Like some sort of illness or something like that. So but that could be done. That could be done in silico once you understand all the parameters of what's there and who's talking to who, right? So that, okay. So I got a question in there in the chat. So the question is whether this can lead to non-invasive measurements of gastrointestinal motility, especially in children. Okay, so Dr. Alexander, Chandran Alexander from pediatrics. And that's not something that you've thought about yet, but it seems like, again, pretty valuable, right? Because we don't necessarily want to be poking and prodding these kids all the time. We'd like to understand how their GI system is working and when it's not working, and right? So do you want to answer that?
Yeah, I think there are different ways to do the measurements. I'm not a domain scientist in the pediatrics, but I do have two kids. So they do have a lot of different activities every day. And in addition to the invasive measurement, you do a lot of inspection and clinical tests, but also you can do a lot of variable sensors to measure those kids. And also, even if you don't even have variable sensors, you could use the remote sensors like the video camera. You can monitor their daily activities, right? And then, but when it comes to the data connection, definitely there are different ways, and we need to talk with domain expert about what are the innovative ways to connect those data. So once we got those data, it's a data analytics and also computational modeling, and then how to leverage this model not only just from one kid, but also from multiple kids. And also if you can extend to the large-scale population study. But at this moment, maybe focus on individual kids. Kids may have different problems, right? They can have their autisms and also different kind of kids pediatric issues. So when it comes to a specific problems, and I think communication is very important, especially bilingual. So when I first get into the cardiology, I'm not trying to claim I know cardiology, but I spend a lot of time in the cardiology department and observing the experiments, observing the procedures, and see how they do the EKG and all the ways that they analyze the signal. But we do know how to analyze the signals. For example, I give them lectures or tutorials on how to do the frequency analysis of the signals. And when they connect the signals from the device, they are all in the binary format. They couldn't even decode the data. And it's very easy for us. It takes us seconds to decode the data. But what they see is 0101, that they couldn't decode the data. And then once I gave them my tutorials, they immediately they got the data, and not necessarily in the text format or Excel format, but in the binary format, how do you decode the data? And once they get the data, and they have a lot of ideas, and then if we can interact and talk about those problems, and I think it's very important for us to talk with our College of Medicine colleagues. So that's why we hope to build a platform that College of Engineering faculty can interact with College of Medicine faculty, so that we actually carry out the interdisciplinary, the true interdisciplinary research, and according to the Sarah's vision of interdisciplinary research. Very much appreciate Sarah for the opportunity. Yeah. I think Sarah,
Then I guess if I'm free to, you got to thank you there on that one. So I guess if I'm free to ask one last question here in the last couple of minutes. So, I have this program that was funded by the strategic plan at the university level called SPARK, Stimulating Partnerships Among Researchers and Clinicians. And I wish I'd had a conversation with you before I developed that, because I was looking for people who had had authentic sort of bonding experiences across that bridge. And so your experience at the VA with the cardiology unit and your experience with electrophysiologists are exactly sort of what I be looking for to partner up. And so I wonder if you can just reflect on those experiences and experiences you've had since you've come to Penn State about, like, how do we increase the likelihood of that happening? Or what do you think is the best sort of protocol for having people meet, but not just meet, but like once you were talking about the cardiologist coming to your lab and watching what the stuff that you did and going to the clinic and following them, which is built into the Spark. But are there any like aha moments that you had about, oh, like this was a gate opener. This was something that really impacted the development of our relationship and the research trajectory? Is that too much?
That's a wonderful question, and I have struggled to find collaborators, and I think finding the right collaborator is a challenge, not just for this kind of collaboration, but for any collaboration. And I think if you want to find a friend and a colleague, you can work together, and it takes time, it takes persistence. For example, when I first get started to work with cardiology, and I'm not very much into the cardiology domain, and especially those kind of disease things. But I have, before I go and talk with my colleague, I have to read a lot of his paper or her papers. And then I get started to understand what kind of problems they have and what kind of language they are speaking. I'm not trying to overwhelm them with some engineering jargons or technical terms. I try to speak their language. So it takes a learning curve. Sometimes it also takes a persistence, because I need to keep bugging them and for meetings, and I need to talk with them about my understanding of the problem and my perspective of the problem, how I can contribute to the science and to the biomedical or clinical science. And then I think because some of them, they are clinicians. Clinicians, they are busy, and they have clinical hours. And I do appreciate it if they spend a few minutes, talk with me, and see whether there's anything we can do. And but they are research scientists in the College of Medicine as well, and they are very open to collaborations. And I very much enjoyed in the past few years to collaborate with many College of Medicine faculties. And I moved from Florida to Penn State about 5 years ago. And the cardiology VA, this connection is actually in Florida. And back then I worked with them a lot. But now I hope to open the new collaboration with College of Medicine and Hershey. And not just for myself and for CHOT. CHOT is a research center. We have a lot of engineering faculties here. but also for the CHOT faculties, even if I'm not the right person, and I can send out the announcement, maybe find the right person for collaboration as well. I do appreciate Sarah for this opportunity to present my research. And this actually opens up the opportunities, especially the CHOT collaboration with the College of Medicine, and we can have more such activities in the future. So that's why I actually had another webinar available, colloquium. So I hope more and more College of Medicine colleagues, they can join those kind of interactive activities. I was hoping some of the College of Medicine faculty who can speak to the College of Engineering audience, and so that people get to know your research and also collaborative opportunities. Yeah, thank you very much, Sarah.
Sure, thank you. That was great. That was very helpful. And so again, if there's anybody in the audience who's a little bit shy about asking a question, afraid of asking a silly question, which they should not be afraid of asking silly questions, right? Because that's how it all gets started, right? It's this beginner's mind that we bring to each other. So at any rate, send Linnell Heimbach an email, or send me an email if you'd prefer. But yeah, I mean, I think finding a venue in the College of Engineering speaker series where we could do a similar sort of thing would be great. I've talked about that with Chris Ron a couple of times, and it's just never really happened. I think the virtual environment now, though, is perfect for it, right? People don't have to drive 2 hours in each direction. They can. So I think maybe you and I can be more leaders on this. So that would be really great, because
Yeah.
I think it is a good thing.
Yeah, very much, 100% agree. And the Zoom make everything much easier.
Makes it much easier, right? All right. Well, then I'm going to close. Stay tuned for next month's RQA. I think that might even actually that save the date may already be out, but we can we'll keep you posted. Watch for the emails. Okay. Have a good day. Bye-bye.
Yeah. Have a good day. Bye.